Hi, welcome to the 11th Annual St. John's Breast Symposium. I'm so glad that you were able to join us this morning. And as many of you know, this is an event that over the last 10 years has grown from a small gathering of 30 people to 300 people last year. With the COVID pandemic, we knew we weren't going to be able to come together in person, but we still wanted to have an event to mark this 11th year. So I do want to thank our team for all of their work to get this event to actually happen virtually. This year's theme is breast health in a new decade. And I'm so very excited about the panelists we have today. Each of our speakers today will give a short presentation about what to expect in breast health in this new decade. And then we're going to follow with a question and answer period, just like we do in person. Please put your questions in the chat box in your Zoom window. You might have to look at the bottom of your screen if you don't see a chat button. Click on the three dots and a chat option should appear. And when you click on that chat box, it should appear on the side of your screen. Type your questions there, and we're going to try to get to as many of them as we can at the end of all the panelists. And just as we do in person, during our question and answer period, we'll also invite any other physicians in the audience on screen to help participate in the Q&A. Before we begin, Kim Spencer will provide a reflection for the day.
Thank you, Dr. Jeffers. I am so pleased to be able to provide the reflection to lead off today's symposium. I'm proud to have been a part of the 10 prior symposiums, and although our 11th will certainly be a bit different, our vision remains the same. I'm standing here in the Cancer Resource Center located at our Camarillo Hospital. I thought it would be a good place to reflect about staying connected even though we are apart today. When we feel connected to others, we share burdens and then we share our strengths, so that ultimately we all feel more powerful and capable in times of need. So I would like to start off this symposium with a reflection by Rachel Naomi Riemann. The most basic and powerful way to connect to another person is to listen. Just listen. Perhaps the most important thing we ever give each other is our attention. A loving silence often has far more power to heal and to connect than the most well-intentioned words. Thank you for logging in today, and enjoy the symposium.
Thank you, Kim. What a great way to start the day. Next, we're going to have Darren Lee, who is our CEO and president of St. John's Regional Medical Center and St. John's Pleasant Valley Hospital, to give us a welcome.
Welcome to the 11th Annual Breast Symposium. I am Darren Lee, the president and CEO of St. John's Regional Medical Center and St. John's Pleasant Valley Hospital in Camarillo. Thank you for joining us today. While we are undoubtedly living through unprecedented times, we remain committed to your health and well-being. Today, we have a great program lined up for you. We have the latest in breast health from the region's top breast health experts. I hope that you enjoy our time together today. Thank you for joining us.
Thank you, Darren. And now it's my pleasure to introduce Haley Jeffers, who is the founder and president of Students Take on Cancer at Rancho Campana High School. This group of students has been raising money for the Cancer Center for the last 3 years, and she wishes to give you a special message.
Hello, thank you for having me here today. Some of you might already recognize me from last year. I'm Haley Jeffers, and I'm the president of the club Students Take on Cancer at Rancho Campana. Last year, our club was able to raise $1,600 to help bring a cancer resource center here to Camarillo, which we were so excited to see opened in February. Having a local cancer center in the area was important to us because we wanted to make sure that everyone had access to the resources they need, especially when you might no longer be able to drive long distances. And as I was thinking about it, I realized that kids who have a parent with cancer might face the same problem. They might know about resources, but they can't access them because the parent that would usually drive them is the one that has cancer. So this year, our club is launching a virtual support group for kids with loved ones with cancer. Especially now, given the pandemic, I hope we can reach out and help the kids who need support without them needing to leave their homes. We are also continuing to sell our cool ties this year for $6. Check out our website, stoc.glitch.me, to get instructions on how to buy one. The donations will be going to the Cancer Center to help fund our virtual support group. Thank you so much, and I hope you have a wonderful day.
All right, it's time to get started with our panel. I'm so excited about our esteemed panelists. Our first speaker is Dr. Lisa Babashoff. She's a general surgeon, and her talk will be about recent advances and new innovations in surgery.
Hello, my name is Lisa Babashoff. I'm a general surgeon here in Oxnard. I also work in Ventura, and I've been doing these conferences since the beginning. This is our 11th year now. This is obviously a little different, first time we've done it this way, but I'm actually really looking forward to it because it's the first time I can bring you into my real workspace. We're in the operating room in St. John's right now, and my talk, I'm going to focus on some of the new innovations that we have here at St. John's. That is two machines specifically that we don't have, as far as I know, anywhere else in this county. I mean, maybe there is someone, I won't want to quote myself on that, but around here, it's the only place that I can use this new technology. So the first thing I was going to talk about today, well, let me back up a little bit and say, so a patient comes into my office, they have an early stage breast cancer. We get them set up to have surgery. Surgery is usually the first step, so they'll come talk to me about their options. One of the main options for an early breast cancer is lumpectomy with a node sampling under the arm. So a lot of women, of course, want to save their breast if they can. There is no decreased survival rate. There is no increased risk of recurrence if you choose to have a lumpectomy, if you fit the requirements for that. So patients, when they traditionally got set up to have a lumpectomy, we bring them in a few hours early to the hospital, send them to the radiology suite where they would then get a wire placed into the tumor so that I would have a guide for where the tumor was. Not everyone, but there was a percentage of those patients who really felt a lot of pain with that procedure. It also was a little time consuming for us. We could only do one surgery like that a day. The patient had to sit in the pre-op area for multiple hours. And there's certain patients with different breast shape, either small breasts or patients who have implants who didn't qualify for getting the neolocalization. So nowadays what we do here is we have what's called our Savvy Scout. Basically, this machine works by radar. So what happens is the patients, once they've decided they want a lumpectomy, they get set up to go see the radiologist in an outside center on any day, any time. It can be done years before the procedure. And they get a little clip placed into the area of the tumor. And that clip then is identifiable for me in the operating room by using this little probe here. So we sterilize it, and with the patient on the table, it won't work right now because there's no probe in here, but it'll let me know by a series of clicking noises where exactly the tumor is, and I can get very specific with it. It goes down to a millimeter, so I'll know exactly where it is. So it's a good technique for finding tumors that doesn't involve placing a wire right before the procedure. We also are working on trying to have patients who look extremely high risk as far as their mammogram showing something that looks very suspicious for a tumor, to have that clip placed right at the same time that they're there getting their biopsy, so they don't need to have a second procedure. So that would even save more time. And that should be soon in the future too, hopefully in the next few months. So the patient then comes to the operating room. I'm doing the technique. This is the operating, I guess you can't see, but anyways, we're in the operating room, the bed's right here. So the patient comes in and has the procedure. I take out the portion of tissue with the tumor. And as anyone who's listening that's been a patient of mine knows, the most important part of that is to get a clear margin around the tumor. We can't have the tumor coming up to the edge of where we take it out, or there's a much higher risk of it coming back. So typically what would happen is we do the lumpectomy, and then the patient would go home, come back to see me in the office about 5 days later when we have all the permanent pathology. And then I tell the patient, yes, the margin's clear, or no, the margin is not clear, which would require a second surgery. That still does happen sometimes, but with this new machine that we're going to talk about next, it's hopefully going to happen a lot less. So what this machine is, this is called our Mozart, and this is a new addition in the last few months. It's a great addition in that once I take the specimen out, I then place it into the Mozart. This is a X-ray machine, self-contained X-ray machine that's 3D. It's very accurate. I place the specimen in there, shut the door. It takes a picture of it, which comes up initially as an image on the screen. So what I'm going to show you now that you'll see on the screen is what exactly I see during the procedure. It's a 3D image that goes from each direction of the specimen, and you'll see that there's a clip in there. That's the Savvy clip that we use to localize the tumor like I was talking about initially. So what I want to see with this video is the clip and the tumor, if we can see it, is it in the center of the specimen from all different angles? Like I said, it's 3D. So what this does in the operating room is it allows me not to take extra tissue that wouldn't necessarily need to be removed. Typically what I had done is I would do the lumpectomy specimen, and then I would take more tissue, kind of like an orange, and then I'd peel more tissue out from all around the tumor in the patient's breast, just to try and ensure that the margin is clear. But it was really just, it wasn't really accurate. It was just me going by just location and not really knowing where the tumor was specifically. So now I can focus any needed re-excisions to where it looks like it needs to be. If the tumor looks like it's a little closer to the superior edge, then I can just take a little bit more tissue from just that one edge. So it saves normal breast tissue that wouldn't necessarily need to be removed. So it's been a really big benefit, and we have it here, and I'm really looking forward to using it a lot in the future. So basically those are the two new innovations that I wanted to talk about today, and I'm just glad that I got to actually show you in person, and it's been a pleasure. Thank you.
Thanks, Dr. Babashoff. How exciting that is. All right, next we're going to have Dr. Lisa Brandt, who is also a general surgeon, and she's going to talk about when to see your doctor.
Hi, I'm Dr. Lisa Brandt. I'm a general surgeon in Camarillo, and I wanted to talk to you today about some common breast symptoms and when you should see a doctor. These include breast masses, abnormalities on your imaging studies like your screening mammogram, nipple discharge, nipple retraction or skin dimpling, breast redness, and breast pain. A lump in your breast or a breast mass is probably one of the most common symptoms and is one of the more concerning ones. Any new mass that you feel or that your doctor feels, or any changes in any existing masses are something you need to see a doctor about. That's why it's important to do a self-breast exam so that you notice any changes in your breast. Abnormalities on your screening mammogram is another common cause that you would see a doctor. You don't always notice any changes, but the radiologist will tell you if there are any changes. That's why it's important to start getting your screening mammogram starting at age 40. They can find early signs of cancer like architectural distortion or microcalcifications. And the radiologist will be able to tell you which calcifications are concerning and which aren't, because not all of them are. Ultrasounds are also sometimes done with the mammogram, especially in women who are younger and have dense breasts. MRIs are another type of breast imaging, but we don't usually do those unless you have a strong family history or abnormalities on another imaging study. Nipple discharge is another symptom that some women can have. It's concerning if it's bloody or clear, if it's from a single duct, and if it's spontaneous, meaning not when you're massaging your breast. Those are things you need to see a doctor about. A nipple rash can also be a sign of what's called Paget's disease. It can be a raw, scaly, vesicular rash that can be associated with breast cancer in about 80% of women. But half of these women also notice a mass. Nipple retraction or any changes in the direction that your nipple points is something to come see your doctor about. It could be a sign of an underlying cancer. Breast dimpling or any kind of indentations in the skin of your breast or change in contour is also something you'd want to see your doctor about. It could be a sign of an underlying mass or tumor. Any breast redness could be a sign of an infection, and you want to see your doctor about that. This is more common in women who are breastfeeding, but it can happen in women at any age as well. So typically we'll treat with antibiotics if it's an infection, sometimes drainage if it's an abscess. Occasionally it can be a sign of a type of inflammatory breast cancer if it doesn't respond to antibiotics, and that's something that we would do a biopsy for. Breast pain, rest assured, is almost never a sign of a cancer. Cyclical breast pain is very common in women, meaning it comes and goes with your menses. Usually I recommend NSAIDs like ibuprofen, and sometimes a supplement called evening primrose oil can help as well. Occasionally breast cysts can also cause pain, and sometimes we can aspirate these, but these are very rarely a cancer. So usually breast pain symptoms are not a sign of a cancer, and just to be assured of that. So in summary, any lump or mass that you feel on your breast, especially if it's new or has changed, is something you need to see your doctor about. Any skin dimpling or change in the direction of your nipple is something you want to see your doctor about. Any nipple discharge, especially if it's bloody or from a single duct and spontaneous, is something you want to see your doctor about. And as well as any breast redness or rash is something you'd want to see a physician about. Thank you for allowing me to speak today, and I look forward to the question and answer session.
Thanks, Dr. Brandt. That was very helpful. All right, well, our next speaker is Dr. Lin Kong. She's an oncologist, and she'll be speaking on personalized breast cancer treatment.
Hi, I'm Dr. Lin Kong. I am a medical oncologist with Ventura County Hematology Oncology Specialist. I am here today to talk to you about personalized breast cancer treatment. So how do we decide what is the best treatment for you? Well, we look at the characteristics of the tumor, including the size, grade, whether or not the lymph nodes are involved, estrogen receptors, progesterone receptors, HER2 status, the Ki67 level, and whether or not there's a metastasis. We also look at characteristics of the patient. What is the age, menopausal status, other medical illnesses, and of course, patient preference. Let's look at early breast cancer to start. What treatment options do we have? Well, we have hormone therapy, chemotherapy, and targeted therapy. But what do we use to decide? Primarily, we look at estrogen receptors, progesterone receptors, and HER2 status. And this will help us determine whether chemotherapy, endocrine therapy, or targeted therapy is best. We also have other tools that we can look at to help guide treatment. I'm going to go through all of these in a little more detail. First is genomic testing. And this is a way of looking at mutations in the tumor cell that can predict how aggressively it will behave. There are several companies who offer this test. The one I use most commonly is called Oncotype DX. I have an example here of a case report. And this patient has a recurrence score of 32. Anything over 25 is considered high risk, and a patient would benefit from chemotherapy. They will also give you a risk of recurrence at 9 years, which in this patient is 20% if she only does hormone therapy. Adding chemotherapy will make that statistic better. There's also an online program called Predict Breast Cancer, and this is available online. You can input data from an individual patient and tumor, and they will give you a 5, 10, and 15-year overall survival and benefit from doing surgery alone, hormone therapy, and chemotherapy. So this particular patient, for example, would have an overall survival at 15 years of 74% with surgery only. That survival would improve to 80% with the addition of hormone therapy, and with the addition of chemotherapy, her survival is expected to be 85% at 15 years. There are also NCCN guidelines available online for physicians to help guide cancer treatment, and these guidelines compile years of research in guiding the best treatment for an individual patient. So what is targeted cell therapy? Well, targeted cancer therapy is looking to attack specific proteins on the surface of a cancer cell. For example, if your tumor has evidence of estrogen or progesterone receptors, we recommend endocrine therapy. The exact medication that we pick is dependent on your age and menopausal status. So for example, if you're premenopausal, we recommend tamoxifen. If you're postmenopausal, we recommend an aromatase inhibitor with anastrozole, letrozole, or exemestane. If you're HER2 positive, we would recommend treatment that is directed against the HER2 protein, in addition to chemotherapy and hormone therapy. But what if there are no targets? Then we recommend conventional chemotherapy. Now let's look at metastatic breast cancer. The treatment that we offer is still based on most of the same parameters. We still look at estrogen receptors, progesterone receptors, and HER2 status. We also look at age, menopausal status, the location and number of metastasis, and other medical illnesses, as well as patient preference. Medications that are available for treating hormone-positive, receptor-positive disease includes these medications. They can be used individually or in combination. If your tumor expresses the HER2 protein, then we have additional medications that are available. Occasionally, we will also recommend molecular testing or tumor profiling. And this is a way of looking at unique mutations in the cancer cell that can help guide treatment options. In this chart, I have listed several mutations that have corresponding medication that will attack that protein. These are available either by the FDA-approved medications or clinical trials. Overall, for the treatment of metastatic breast cancer, we offer hormone therapy, chemotherapy, targeted therapy, immunotherapy, radiation, and occasionally surgery. Clinical trials always remain a viable option. Either way, treatment of your cancer is dependent on the specific molecular biology of your tumor. Thank you very much.
Thanks, Dr. Kong. I always learn something new every time we have this meeting. Our next speaker probably doesn't need to be introduced, is Susan Spear, and she is our resident nutritionist and certified in oncology nutritionist. She works at our breast center and cancer center. She's going to be talking about nutrition in the new normal.
Hello, and thanks for coming here to the nutrition office at the St. John's Cancer Center. And thanks to Dr. Jeffers, who's just introduced me, Susan Spear, as the cancer nutrition expert here. And I gotta thank Dr. Jeffers too, because I think she came up with my snappy title for my talk, Nutrition for the New Normal. And I love that title because it gives us a great jumping off point for thinking about what is the new normal for cooking and eating right now in this extraordinary times. Is there anything new in the science-based recommendations for breast cancer prevention and treatment? And what's the interaction between the two? We're seeing right now that about 70% of us are doing more grocery shopping and cooking more at home. And that can be a good thing because previous surveys have showed us that people who cook more and eat more at home tend to have healthier whole food diets with more fresh produce. And about 40% of us are saying that we think we are eating a healthier diet. 20% of us are saying that we're gone the other direction. But even though most of us think we're eating a healthier diet, we're also saying that we're snacking more, we're eating more frequently, and that may be the reason why some of us are saying we've put on the quarantine 15, that we're gaining weight. And of course, that's the wrong direction where breast cancer prevention is concerned. We know that women who are overweight or obese are more likely to get breast cancer in the first place, especially postmenopausal breast cancer. We know women who get breast cancer that are overweight or obese tend to have greater risk of recurrence, and even women who gain weight during chemotherapy have poorer outcomes. So keeping a lid on weight gain is important for preventing breast cancer and preventing recurrence. But if weight has always been a difficult issue for you, don't despair, because physical activity can confer many of the same benefits of being lean. So fitness confers a lot of the same benefits as leanness. Physical activity is associated with less breast cancer risk in the first place. 30 minutes of moderate physical activity like walking on most days of the week helps to prevent breast cancer, and it will even help to prevent breast cancer recurrence. 3 to 5 hours of exercise per week seems to decrease breast cancer recurrence between 20 and 40%. And even one of the latest studies says even just 2 hours helps to prevent breast cancer recurrence. It's also one of the healthiest and safest things we can do during this time. And it's great stress management too, besides reducing our risk of breast cancer. And that's an important thing because another thing that these surveys about our new normal of cooking and eating have shown is that some of us are drinking more alcohol. And once again, that's the wrong direction to go in terms of preventing breast cancer. Now, the average woman apparently drinks about 4 to 5 days per month. And this increase in alcohol intake seems to have added another day a month of alcohol intake, so 6 days a month. And if it's 6 drinks a month, we're all in the safe zone. But if it's an alcoholic drink every day, that increases your risk of breast cancer. And for any of you who've already had a diagnosis of breast cancer, drinking more than 3 to 4 alcoholic drinks per week increases your risk of recurrence. You can see those recommendations in this handout that you should have received when you registered for this conference. On the second to last page in this handout, you can see those recommendations that I just spoke about, and you can even see that there's some emerging research there that says that eating more vegetables and fruits, and especially carotene-containing fruits and vegetables, which are the dark orange things like mango and cantaloupe, winter squash, that those seem to be protective against breast cancer. But you may be thinking, gee, why isn't the evidence stronger for that? You can also see that for preventing breast cancer, that eating dairy and calcium may be protective, and that may be something that's confusing because if you get on the internet, it seems like dairy products are a problem for breast cancer. And you can ask me about that during the question and answer period, and I'll tell you some of the nuances of that controversy. But I think it underscores the fact that there's no single food that confers benefit or harm for us in terms of breast cancer, that it's more whole diets. And we can see that in some of the big observational studies, like the Swedish mammography study, which took 30,000 women and followed them for 15 years and rated their diets about how well they are meeting the 8 to 9 recommendations for reducing the risk of cancer. And in that handout, you can see those recommendations too on that second to last page. So women that met 6 to 7 of those 8 to 9 recommendations cut their risk of breast cancer in half. And even if you only met 4 to 5, it cut your risk of breast cancer by 30%. In the Women's Health Initiative, which is another interesting large study, they looked at just low-fat diets and more fruits and vegetables, and they found that there was a trend for less breast cancer incidence, but it didn't reach statistical significance. Once again, just looking at a few things instead of the whole picture. Interestingly, in that study, after 19 years of follow-up, women who did get breast cancer who were in the dietary intervention group, eating less fat and more produce, they had about a 21% less chance of dying of breast cancer. So it worked to help prevent the recurrence and to give them a better outcome. And they also had about 40% less cardiovascular disease. So it's the whole picture that we need to look at in terms of preventing breast cancer and keeping it from coming back. And if you are new to cooking at home, taking advantage of this time maybe to eat healthier, I want to encourage you to not order a bunch of cookbooks on the internet and think about making fancy meals, because simpler meals tend to be healthier. So if you've got a rotisserie chicken or a fish fillet or a handful of canned beans and you add a bag salad to that, and maybe you make your own sweet potato to add to it and a handful of blueberries with a dollop of vanilla yogurt for your dessert, that's a really healthy meal. And fancier with sauces all over everything or goopy casseroles, those are less healthy for you. And in that handout I sent you, there are some ideas about what a healthy plate looks like. And there's many more healthy fast meals in there too. So take a look, get in the kitchen, make some healthy meals, walk for stress management and also to decrease your risk of getting breast cancer, and eat well and live well for your health. And I'll see you on the other side for question and answer period. And at that time, you can ask me about the calcium and some other things. And there's some other good information in this handout if you want to ask me about that too. I'll see you then.
Thanks, Susan. You're always a tough act to follow in these panels. All right, next and final speaker that we have today is Alicia Zaragoza. She's our nurse navigator at our cancer center. She'll be talking today about staying connected and self-care, especially during this pandemic.
Hello, My name is Alicia Garza, Certified Breast Nurse Navigator. The health and well-being of our patients and community is our number one priority, which is why at the Integrated Breast Center at St. John's, we offer various services to support our patients through their cancer journey. From personalized treatment to nutrition counseling and emotional support, our center is here for when patients need us the most. We also provide our patients with wigs, bras, prostheses, and other tools they may need during treatment. At the onset of COVID-19 in Ventura County, we went to great lengths to ensure patient care was not impacted, so we quickly strategized ways to remain connected. We integrated various communication methods such as Zoom, FaceTime, text, and email. Most commonly, we use Zoom to facilitate support groups, including bilingual support groups, nutrition counseling, navigation, and other one-on-one consultations. Be there a pandemic or not, we remain committed to providing our community with the tools and resources to advocate for their health, which is why I would like to take a minute to discuss self-care. Now more than ever, it is important that we all continue scheduling our routine health screenings, which include breast screenings. Whether it's a wellness visit, a mammogram, an ultrasound, or a breast MRI, it is essential to stay up to date with your health. Don't put off these life-saving screenings and encourage your loved ones to do the same. Our hospitals and imaging centers have established enhanced protocols to ensure your safety when you visit us. Remember, prevention is key and early detection saves lives. We are all in this together. Thank you for joining us.